Yes. Good afternoon. So, try to put up with one more lecture, and then we'll have a coffee break again. So this was the title that Gustavo gave me. I had to think a little bit about it, and but I think I understood what he meant, and I hope that I will also convey this message to you. Which are the learning objectives of my lecture? I hope that you will get acquainted with the phenotypic expressions of Noonan syndrome, learn about the antenatal features, the indication for Noonan testing, the limitation of the prenatal diagnosis of this syndrome, the prognosis, and the counseling. Well, I will start by telling you my first live experience with a Noonan individual. I was doing a scan, and it was a 32-year-old lady who had become pregnant after donor IVF. And at 30 weeks of gestation, she was referred because both fetuses had an increased nuchal translucency. One had a CRL which was much shorter than expected for the gestational age, and a nuchal of 8 millimeters, and the other one had an increased nuchal, but not that increased, about 4 millimeters, and a normal CRL. We scheduled an amniocentesis because she didn't want a CVS, and the amniocentesis was performed at 16 weeks, and by that time, the small fetus with the NT of 8 millimeters had demised, that died in utero. We did the amniocentesis also in that sac, and the result was that the small fetus had a trisomy 18 and the other one a Klinefelter syndrome. But what was very special to me, I was telling to the geneticist, you know, I'm not convinced that this woman is normal the more I look to her. And it's not this one, but let's say something similar. She was obviously blonde because she was a Dutch. So I would think that she has got Turner syndrome, but I mean, it doesn't really fit with the fact that she's pregnant. And then the geneticist, as a matter of curiosity, came with me to see this patient, and she told me, oh, but she has got Noonan. And so that was for me the first time, my first encounter with Noonan. This woman was, for the rest, perfectly normal. She was a top sporter. She was indeed rather short, a little bit more than shorter than me, but even not that much. And indeed, this woman had Noonan syndrome. So in the Netherlands, there is a specialist, this Van der Burgt, who is a great geneticist, who is a great Noonan specialist, and she has formalized some criteria to diagnose Noonan syndrome. I will not go through it, but if you are interested, you can look it back. And then I will tell you of a few other cases I came across. This one, well, recent cases. This one was a 12 weeks pregnancy referred because of an enlarged nuchal translucency with septations, and the nuchal was 11 millimeters. There were no other obvious anomalies. We did a CVS, and that was normal, and the arrays were also normal. Well, usually I like to see back these patients at about 14 weeks, 15 weeks, but sometimes something goes wrong, and this lady was not seen until the 20-week scan, and which was in actual fact done on 19 weeks. And at 19 weeks, what it occurred to us was that there was a kind of a brachycephaly. Let's say the head, there was not a big difference between the anteroposterior and the transversal diameter of the head, and there was still a persistence of this nuchal edema in the form of these jugular sacs. And you could also see a clear nuchal thickness. At that point, we suggested to our geneticists to do a testing for Noonan. They don't like it because they think that it's not a very severe condition and it's very expensive and it's long-lasting. Well, in the end, they did it, and this lady was pregnant with a fetus with Noonan syndrome, and the parents choose to terminate the pregnancy. And this is another case. This was a patient who didn't come for the first trimester scan. She was, in actual fact, a refugee from another country. We have a lot of those in the Netherlands. And she presented at 20 weeks, referred because she had an enlarged nuchal fold, polyhydramnios, and, well, you can see clearly a kind of a cystic hygroma, and also on this picture with enlarged jugular sacs. And at that point, because of the first experience, our geneticist agreed to test for Noonan syndrome, but the answer was no mutation in the PTPN11 gene, so this woman hasn't got a Noonan syndrome. Well, we followed up the pregnancy, and what we saw was that the polyhydramnios was increasing, and there was no ascites. And what it really was very striking was the fact that the heart was enlarged, and it had a very strange contractility. The fetus was macrosomic. There was a hepatomegaly. And I said, I think that this fetus has got Noonan syndrome. Well, obviously the geneticist said, well, no, that's not possible. The mutation was not found. So, and this was the typical 3D picture of the face. And here I show you that the growth, that the fetus was indeed large, macrosomic, and this was the hepatomegaly and the increase in amniotic fluid. Well, these were the pictures of the fetus. And, well, what we know is that the PTPN analysis, although is the most common mutation in Noonan syndrome, accounts only for 50% of the mutation and is found in respectively 16% and 2% of the fetuses with cystic hygroma and enlarged nuchal translucency. This was out of a series of 134 cases from Lee. So the baby was born and rather large for the gestational age. And this was the description of the geneticist: edematous, short stature, elongated skull, hypertelorism, small eyes, long philtrum, pronounced lips, low ears implant, hydropic and overfolded helix and thick earlobes, retracted nipples. The liver was indeed palpable, and there was a hairy dimple on the back, 4 fingers line, and the legs were curved with the pes adductus and skin syndactyly of the second and third finger. So there was for sure a syndromal aspect, and they decided based on this to do additional investigation. And in actual fact, a lot of syndromes were suspected, as low and other syndromes. This was the baby when he was 3 weeks old, and at a certain point it was discharged, and before the baby was discharged, cardiomyopathy was confirmed, and well, the extended DNA diagnosis, because at a certain point they even thought of Miller-Dicker syndrome, revealed a Noonan syndrome, but this time based on a pathogenic mutation in the RAF gene. Well, here something went wrong, but anyway. The infant died at the age of 6 because of the cardiomyopathy. So in my opinion, this also based on the experience that I had previously with Noonan syndrome, is that when you see prenatally hepatomegaly and cardiomyopathy, usually the prognosis is bad, because in a case of where I saw hepatomegaly, the baby developed after birth a kind of a leukemia syndrome, leukemic syndrome that then resolved, but in the end also that baby died of other complications. And this is the last case, and in actual fact it's very recent, of last week. At 12 weeks, this lady had a fetus with a very enlarged nuchal translucency, also with septation. QF-PCR was normal and arrays were normal. And again, she came back at 14 weeks, and what we say, well, our protocol I will show you later, but let's say the protocol was not respected. At 14 weeks, there were cystic hygroma, no intervention was taken, and the patient was brought back again at 19 weeks. What we saw at 19 weeks is that the baby was large for gestational age, and very, very active. I show you some little clips. And this is the 3D reconstruction of the face, not that good because the baby was so moving, but you see very clearly the low implant of the ears, the very broad face, the hypertelorism, the depressed nasal bridge, and we also measured indeed the distance of the orbits. And what was also very special in this fetus that there was no ductus venosus visible, and the inferior vena cava was very dilated as compared to the vena cava superior. So here you see how active the baby is, and there are indeed the typical facies is appearing every now and again, and the dilated jugular sacs. And here we see again the heart with this rather enlarged if we compare it to the thoracic circumference, and also with a disturbed contractility. Well, you may think what I think it is, but the diagnosis for Noonan has been just requested last week, so I don't know yet. So I will let you know what will be the final diagnosis, but I think it's very, very suggestive. Why is Noonan syndrome so important? Well, it is important because it has got a very high association. It's the genetic syndrome which is most commonly associated with an enlarged nuchal translucency. Well, this was a paper where we looked at the outcome of 451 fetuses with a nuchal translucency above the P95 and normal karyotype, and as you all know, even if the karyotype is normal, the chance of a poor outcome is present, and it increases progressively with nuchal enlargement and varies from 10% until 80% according to the initial degree of enlargement. We have also proposed a kind of a table which may be useful according to the degree of enlargement to counsel parents about the chance of miscarriage, of a genetic or structural anomaly, and adverse pregnancy outcome altogether, according to the degree of enlargement. Well, in actual fact, what we saw is that 20% of the fetuses have a poor outcome, and that can be subdivided in 4% spontaneous abortion, 7% structural anomalies, 5% genetic syndrome, and in a minority of cases, parents decide to terminate the pregnancy because they don't dare to continue after the counseling. As far as neurodevelopment is concerned, genetic syndromes accompanied by a poor neurodevelopment are not that high, about 1.6%. And the most important anomalies that we found, structural anomaly, are in actual fact a heart anomaly, accounting for 6%, and also here it holds the fact that the thicker the nuchal and the higher the chance that you will find the heart anomaly, ranging from 2% where the enlargement is minimal to 10% there where the enlargement is conspicuous. And the other association that we find quite regularly is with cleft. And in actual fact, we saw that the relative risk for any facial cleft after a normal karyotype is 19, 8 for isolated, and 53 if the cleft is associated with other anomalies. When it comes to the genetic syndrome, well, you have heard already many names in these days, and not all of them are associated with enlarged nuchal translucency, but the ones that we are writing down here are. And of all of them, many are sporadic, but the association with Noonan syndrome is for sure not sporadic. In actual fact, in this paper of Pergament, he looked at 120 fetuses with normal chromosomes after a nuclear translucency of more than 3 millimeters, and he tested for the 5 most common syndromes, and a mutation of the PTPN11 gene was found in 8 cases, so which means that in about 7% of the cases of enlarged nuclear translucency with normal karyotype, a mutation for Noonan will be found. In our publication, we had a number of genetic syndromes that were discovered postnatally. And if you look at this genetic syndrome, and you have here the NT enlargement, and the ultrasound findings, the outcome, and the diagnosis after birth, well, you will notice that Noonan syndrome is represented twice, and Leopard syndrome, as I will explain you later, belongs to the same family of Noonan syndrome. Characteristic of this situation was that the nuclear enlargement was conspicuous, 6, 5, 7, and there where we didn't see anything at ultrasound, well, it was, some of them were 15 years ago when, let's say, the equipment was not that good and not equally experienced people did the scan. So we missed some anomalies, but let's say in general, there were not striking anomalies in these cases. And in one case, there was a neonatal death. In another case, a mild developmental delay. And in the last case, a completely normal development. So Noonan syndrome occurs in about 1 in 1,000, 2,500 fetuses, is mainly a de novo mutation, but when it is not, when a parent has got Noonan syndrome, the inheritance pattern will be autosomal dominant. The typical phenotypes are short stature, short webbed neck, the pectus excavatum of carinatum, hypertelorism with a typical downward eye slant, epicantic fold, low set ears, and heart defects. And these heart defects are particular heart defects, and I will discuss them later. The individuals have very often curly hair. And this is a number of Noonan individuals. And well, you will see, I am aware that they are rather small, but some of them look pretty normal. There is an enormous variation in the phenotype. And what we know is that there is also an enormous variation in the presence of in the presence and in the degree of mental retardation, which will vary from 15 to 35%, which means that the postnatal diagnosis of Noonan syndrome is quite difficult owing to the great variability in phenotype and in clinical manifestation. And what is also peculiar is that the facial phenotype changes with age, becoming less obvious with age. These are also some graduate ladies with Noonan syndrome. You wouldn't say that. So when should we suspect the Noonan syndrome prenatally? Mirol Bakker, who is from our group, and she's also here in the room, has written this very nice review where she has put together all the evidence in the literature until that moment. And a total of 42 cases were collected, and she looked at the ultrasound features. And what you can see, 84% of the cases had increased nuchal translucency, distended jugular sacs in 22%, increased nuchal fold or cystic hygroma in 80%, and then all kind of edema, pleural effusion, ascites, scalp edema. And then there are typical facial features, which are brachycephaly, hypertelorism, loss of tears, broad nose, broad lips, and the last two present in more than half of the fetuses. Cardiac anomalies were also present, and polyhydramnios is also a very, very common feature. And now I will show you what is known in the literature. This is an article from the Acheron group from 2000, and they looked at all the cases of Noonan syndrome diagnosed prenatally or postnatally in their institution. And the prevalence was 1 in 4,000, and they had a total of 11 fetuses, no, 4 fetuses and 7 infants, altogether 11, with Noonan syndrome. So of the fetuses, one had a transient nuchal translucency, which means that the nuchal translucency resolved after, let's say, after the 14 weeks. But later, the fetus developed hydrothorax and skin edema and polyhydramnios. In the other 3 cases, the first and second trimester ultrasound findings were normal, and the diagnosis of Noonan was suggested only later on in the 3rd trimester because of polyhydramnios and skin edema, and then there was a case with a cardiac defect, hydrothorax, and a larger head. The typical heart anomalies which we see with Noonan are pulmonary stenosis, and you all know that the prenatal diagnosis of pulmonary stenosis may occur only late in prenatal life. And, but there are also some cases of aortic stenosis, but the most common are pulmonary stenosis and cardiomyopathy. And also cardiomyopathy is a condition that you may not see at 20 weeks. So the conclusion of the second paper was that Noonan is characterized by late onset and progressive pathologies that may not be seen at 20 weeks. And the sort of cardiac defects are typically cardiac defects that can only be observed later in pregnancy. We see in this case also a conspicuous tricuspid regurgitation. This is another paper which has appeared quite recently. They looked at 47 cases, and in 41% there was an increased nuchal translucency, 38% polyhydramnios, 21% abnormal generic ultrasound scan, but in 43% there were no anomalies in these 47 cases of Noonan. So their conclusion was abnormal ultrasound is frequent, but not specific and not useful for the prenatal prediction of the postnatal phenotype. In other words, ultrasound does not predict or exclude Noonan genotype or postnatal phenotype. Fetal anomalies at ultrasound, when they were present and they were serious, were though associated with developmental delay and intellectual disabilities and juvenile myelomonocytic leukemia. And this is also our experience, this is a third point. And this is a very recent paper from a French group, and their conclusion is exactly the same, that there are a lot of anomalies. The most common are nuchal translucency, cystic hygroma, polyhydramnios, but the conclusion is that prenatal ultrasound features of lymphatic dysplasia do not predict an unfavorable postnatal prognosis for Noonan syndrome. Well, if it gets to the genetic side, that's also quite tricky, because there are 7 different genes that can cause Noonan syndrome. And although the PTPN11 accounts for 50% of the mutation may also occur in one of the other genes, so which means that it's very difficult to exclude with certainty Noonan unless we go through all of them, and this diagnosis is quite expensive and long-lasting. Only recently there have been some improvement in that respect, and there is also an overlap with other syndromes like Leopard syndrome, Costello syndrome, and cardiofacial cutaneous syndrome. And that is explained by the fact that these syndromes all result from mutation in the same pathway, the ERK1/2 cascade. And so if something goes wrong, either Noonan or one of the other syndromes can appear. When we think of the pathophysiological backgrounds of a larger nuchal translucency, well, we know that there are different theories, different proposed theory, and one of those is the perturbed migration of function of the neural crest cells. And this is a very interesting paper which shows how Noonan syndrome in mice is in actual fact characterized by a disturbed migration of the neural crest cell and by a disturbed activity, accounting for the typical phenotype of the cranial and cardiac phenotype of Noonan syndrome. And so which means that a significant proportion of Noonan syndrome, typically presenting with both cardiac defect and craniofacial abnormalities, are caused by this disturbed migration and function of the neural crest cells. So in one way, this confirms one of the pathophysiological mechanisms proposed for the increased nuclear translucency. And what is even more interesting is that the same group has tried to correct this phenotypic alteration in these fetuses in which they produce Noonan syndrome by giving them a ERK kinase inhibitor, which managed to reverse the typical phenotypic expression of Noonan in these fetuses. So when we think of the management of the enlarged nuclear translucency, this is our proposed protocol, let's say flow chart. Usually when DNT is marginally increased, well, in the future we may consider in those patients only doing an IPT and then to see them back at 20 weeks and maybe at 28 weeks. There where the nuclear translucency is largely increased, more than the P99, which is 3.5 millimeters, we want to see them back at 13 weeks, in between 13 and 16 weeks, 20 weeks and 28 weeks. And if they show at any of these points a persistence of nuchal fluid, of jugular sacs, of increased nuchal fold, we will consider testing for Noonan syndrome. And this is also expressed in this protocol, which has been extracted from the publication of Miro. So when we see in the second or in the third trimester persistence of the nuchal fold, of other craniofacial features of edema, polyhydramnios, or cardiac anomalies, or renal anomalies that may be compatible with Noonan syndrome, I think is really worthwhile doing this test. And this has also been accepted, endowed by our geneticists in the Netherlands, which have expressed this opinion paper where they recommend the prenatal testing of PTPN11, CRAS, and RAF1 in all pregnancy with an increased nuchal translucency and one of the following features: polyhydramnios, hydrocephalus, renal anomalies, distended jugular sac, hydrothorax, etc. And if negative, they also advise to add testing of two extra mutation, BRAF and MAP2K1. So, having said so, in our paper we also showed that the outcome of increased nuchal translucency after a normal scan, so in those cases where at the 20-week scan we couldn't see any kind of even subtle anomaly, is generally good, even if the initial degree of enlargement was very big, like more than 6.5. Obviously, the number of fetuses was very small because a lot of them had other pathologies, but those where the nuchal disappear and no other anomalies are found can continue the pregnancy and be reassured. My take-home message is Noonan syndrome is a common genetic syndrome and the most commonly associated with an enlarged nuchal translucency of cystic hygromata. The expression of the condition varies greatly before and after birth. Associated ultrasound anomalies are frequent but aspecific and poorly predictive of postnatal development. Prenatal diagnosis is challenging owing to 7 different genes involved, possible normalization of nuclear translucency, frequent late onset of anomalies, and sometimes these anomalies are only discovered in postnatal life. But mental development is usually good, and so I would suggest not to be too much afraid of Noonan syndrome. And I thank you for your attention.